Thanks for having me. It's an honor to talk to you today. Um, when people ask me why I became a urologist, one of the most appealing factors about urology is that we have to deal with a diverse number of conditions, going from prostate cancers to incontinence, kidney stones, BPH, benign prostate hypertrophy, and also topics like erectile dysfunction. So today is just going to be a very condensed, focusing on both prostate cancer screening and erectile dysfunction. I certainly wish I could have more time to talk to you about all these subjects, but I'll take any questions you have at the end of the talk, and I'll make this short and sweet. I don't have any fancy slides, so I'm going to talk to you like I would be talking to you if you came to see me at the office. So then, as a urologist, we deal with mostly men. BPH, which stands for benign prostate hypertrophy, the prevalence of that goes up with age. So if you look at the cohort of men who are 50, then 45 to 50% of us are going to have some element of BPH and symptoms associated with it. Our prostates get bigger as we get older, but not everybody has symptoms. And so as a urologist, when you come see me and we talk about how you're doing, I want to know how happy you are, how satisfied you are with your symptoms. I ask you the quality of your flow, how many times you're getting up, if you're happy with the frequency. Have you had any kidney stones? Have you had any UTIs, any infections? Have you had any prostate cancer? And then as you go up with age, if you look at men who are 70, then there's going to be more like 70% of us who are dealing with this condition. BPH, we all have, but this does not become clinically significant in all of us. Now, PSA stands for prostate-specific antigen, and it's a molecule made by the prostate. So any man who has a prostate will have a PSA. Benign tissue makes PSA, but so does prostate cancer. And the concerning behavior of PSA is when it starts going up, because prostate cancer cells make PSA at a higher rate. So again, all of us have a prostate. We're all going to have some level of PSA. Men with bigger prostates are likely to have higher PSAs, and so that is something also that we take into account. It is interesting that September still is Prostate Cancer Awareness Month. And when I was a resident not too long ago, every September we had these prostate cancer days in which men would line up outside the office and everybody had a PSA and a rectal exam done. And it is interesting that I'm in a field of medicine in which we continue to see evolution of how we treat and evaluate patients, because nowadays we are more systematic and we have a more careful conversation with the patients regarding what PSA is, what the implications of even getting a PSA, which is a blood test, and even considering a biopsy down the line. And the reason for that is because the guidelines and the understanding of the biology of prostate cancer has changed over time. Nowadays, we know that most prostate cancers are very slow growing, and therefore we have to be systematic about treating those men that really would benefit from any treatment in order to avoid the side effects that come with any kind of treatment. There was an article in the New York Times approximately 10 years ago that criticized urologists for causing too many side effects, for causing too much erectile dysfunction, for causing too much incontinence, and all the other side effects that come with any treatment for prostate cancer. And then that's when the evolution, that's when the pendulum of PSA testing started to come the other way, because of that, urologists were criticized for causing too many side effects. And because of that, the guidelines, the AUA, which is our organization, the American Urological Association, came up with specific guidelines that now specify that men between the ages of 55 and 69 should be screened for prostate cancer, but these patients should really be evaluated on a case-by-case basis. Again, those guidelines that are also supported by the task force, which is the governmental agency that looks at they work with the American Cancer Society to really cone down on the benefits and the risks of any intervention. So 55 to 69. But if you have, but the basis for that, and the conversation that I have with a man when we consider PSA testing and any further treatments beyond that, then we talk about life expectancy. Most prostate cancers are very slow growing. They're indolent. And so sometimes we like to say that it's something that we're likely to die with, but not from. And really, anything that goes beyond a PSA test can have side effects, implications, and catches. So all that has to be considered very carefully. Even if a PSA is high, then we can consider a prostate biopsy. A prostate biopsy is something that I do in the office, but that also has side effects. We can cause bleeding, retention. There can be a risk of infection, and that risk goes higher every time you repeat a biopsy on someone who has already had one. So, so basically, to summarize the guidelines, again, ages 55 to 69, but it's a conversation that you and your primary doctor or you and the urologist has to have on a individual basis, because if you have someone who's 75 and they want to get a PSA, understanding the implications that PSA can come back high, and then what are you going to do? Are you going to keep an eye on the PSA, knowing that prostate cancer could be a possibility, or are you just going to go to a biopsy, understanding the risks associated with such? Some of the side effects that come with treatment, and I don't really want to get into the subject of prostate cancer too much, but that's something that has to be considered, because when you consider doing a biopsy, you talk to the patient about the possibility that biopsy can come back positive, meaning that there's prostate cancer. If that's the case, then there's also a movement, or if the PSA is relatively low, if the number of biopsies that came back positive is also low, and there's more of the less aggressive type of prostate cancer, we're also doing more active surveillance, which means keeping an eye on the PSA, not pursuing any invasive treatment, but that comes with also the catch that we are likely to recommend a repeat biopsy 18 to 24 months down the line. So bottom line, there's more men nowadays just sitting tight, keeping an eye on the PSA, and holding off on treatment. Again, it's a malignancy. The definition of cancer is something that can go someplace else. It can go outside the prostate, and that is something that no urologist can look at you in the eye and predict 100%. However, now we know, again, that most prostate cancers are slow growing, and therefore we have to make these decisions very systematically, and conveying to you all the risks and implications of doing something or not doing anything at all. So a segue to that then is going to be talking about erectile dysfunction. Erectile dysfunction can be a side effect of any treatment of prostate cancer, not only because of surgery, but also radiation, hormones, freezing, which are the three modalities that we use to treat localized prostate cancer. We also have an aging population. The number of men above the age of 60, 65, i.e. the baby boomers, is increasing as in time. There's more obesity, there's more hypertension, and there's more coronary disease. Like we have seen in the recent talks today, there's also an implication of coronary disease when you have someone who presents with erectile dysfunction, especially if that patient is younger. So the way that I describe to patients the physiology of an erection is that all these stars have to line up in order for a man to have a satisfactory erection. You have to have the nerves, you have to have the hormones, you have to get the blood rush into the spongy tissue that makes the penis in order to attain rigidity. And so then as we get older, it's like the plumbing in your house, it's like the electric system in your house. Things don't work as no one is 20 here anymore. And so the urologist, and no provider can specifically give you one pill that is going to address all those different aspects. Therefore, we are left with treating the endpoint, which is help the patient get an erection. And we do that with pills, which is the easiest and least invasive way to address the issue. Viagra, Levitra, Cialis, Extendra, they all work the same way. They're vasodilators. They achieve the end goal by dilating the blood vessels and getting more blood into the tissue. The catch with these medications is that there's a relative contraindication in using them in men who have access to nitrates for heart disease, like nitroglycerin or other nitrates that are used also to dilate the blood vessels in the heart, because potentially they can cross-react or potentiate the side effects and cause dizziness and a fall. Then we have the vacuum erectile devices, which there's places online that you can buy them. Or you can go to the local store and get one too. And I'm not a big fan of those because they're uncomfortable, they're painful, and also they have to be used with a restrictive device. Once you create the vacuum and you have an erection, then you have to slide a rubber ring to the base to maintain the erection, and sometimes that causes pain, discomfort, and also there's a danger of causing ischemia, which is basically not letting enough blood flow go into the tissue, and if the patient forgets and doesn't take that ring off, then there's going to be tissue death. And then as a urologist, we have more options to give you, and we can also talk about injection therapy. Injection therapy is patients who are diabetics are very familiar with this. It's kept in the fridge, and it's a small vial, and it comes in 5 cc or 10 cc volumes, and the patient learns how to use a very small insulin syringe, which is a 1 cc, to draw a very small amount of this compound, which we call trimix, because it tends to be a combination of 3 vasodilators, and that goes directly into the penis, into the erectile body of the penis, to cause dilation, increase blood flow, and attain and sustain an erection. And finally, we have, as urologists, we also can talk about the option of pursuing surgery, putting a prosthesis, which also come in 3 different models or options. One of them is the malleable, the one that replaces those erectile bodies, the spongy tissue, and you can shape it, you can put it up or down. That would be the easiest and less complicated one. But certainly the one that resembles our normal physiology the best is the 3-piece prosthesis, which uses 2 cylinders, a pump that is placed in the scrotum, and a reservoir filled with water, which is placed next to your bladder. And then when you squeeze the pump, the water goes to the cylinders, they fill up, they get hard, and then when you're done, the water goes back to the reservoir. So bottom line, so to summarize, you have options, and certainly taking a pill is the easiest. It comes with its catches. Again, it's not recommended in men who are taking nitrates. They are expensive. They don't always work. But as urologists, we can go down the line of the options that you should all know about. Doesn't mean that I'm going to recommend a prosthesis to be done right off the bat, but certainly being urologists, we're educators, we deal with male health, and these issues of prostate cancer screening, prostate cancer, and erectile dysfunction, they're all tied together, and so make an appointment, come see me, and something that I really enjoy talking about, and this is exactly what I would tell you if you came to see me as a patient, and I'll take questions now.